weight management peptides like GLP-1s, which are actually GLP-1 receptor agonists like Wegovy, Zepbound, Ozempic, Mounjaro, which are actually just these FDA approved GLP-1s, are very common. And most people hear about them being approved for type 2 diabetes or rapid weight loss. How do you approach these GLP-1s?
The GLP-1s, glucagon-like peptide, was created for type 2 diabetes. As you take a GLP-1, it reduces your blood sugars. That's what it was created for. Now, what they also identified was significant weight loss that occurs with the GLP-1s. The problem with the drugs, and they are FDA approved, is that people have had massive weight losses. I mean, sometimes several hundred pounds. My frustration with the GLP-1s, the way they're given to patients today, is with little to no education. Right now, there's many doctors around this country that if you simply send them a form about your health history, they will send you a prescription and you can start on your own GLP-1s. No oversight at all. And they will send that to you as long as you want. So there's no end game.
What's the problem with losing hundreds of pounds or even 40 pounds in a very short period of time, like a few months?
Well, the main thing is malnutrition. Now, this is unbelievable to think about. If you have a 300-pound person and they lose 50 pounds, and I'm calling them malnourished, and you say, you're still 250 pounds. How can you be malnourished? All of the cells, and again, let's go back to the cellular, the 30 trillion cells. All of those need energy to work efficiently. So if I am not giving myself food, all of those cells are going to become compromised. They're either going to quit working or they're going to die. So we're losing weight. The cells at the micro level are not working well or not working at all. So we become malnourished.
I think something that people maybe don't understand is malnourished isn't just a calorie deficit. It's also a vitamin and mineral deficit.
Absolutely. It's all the things that you need in your body that food should give us. All of those things are necessary for the cell to work. Coenzymes and cofactors. We are seeing something called scurvy that we haven't seen in 200 years, back when we had pirate ships. Scurvy is now increasing because of the severe malnutrition that is occurring with the GLP-1s. It's the lack of fruit specifically. So all of us, to some degree, get vitamin C. Usually it's through orange juice. But anybody with a low vitamin C level, severe, is called scurvy. If we have really low vitamin C, we have severe immune compromise and patients get sick. So we're truly trading one problem for another. When I talk about people's end game, how long am I going to stay on this? What is my goal weight? What do I want to look like? And providers across the country are doing a really poor job in discussing a plan for those patients. All patients should have a specific plan when they go on GLP-1s. That's what we do at Epiphany. We have to understand where we're going. You have to have the replacement of minerals and vitamins that are necessary. We offer a product that we give when we give GLP-1s that addresses the malnutrition that can occur from the lack of minerals and vitamins. So where are we going? What is our food going to look like? What is our activity going to look like during this process of GLP-1s? We strongly disagree with giving GLP-1s without having a plan.
So it's not that you're against this peptide, it's that you want to have someone under very good guidance from a licensed provider. You want them to have realistic expectations of how much weight do they actually want to lose. You're probably going to manage somebody that wants to lose anywhere from 15 to maybe 50 pounds, and making sure that they have expectations and where they're going and the correct nutrition to go along with it. What GLP-1 do you provide at Epiphany?
So we use a GLP-1 called liraglutide. It's Lira glutide. And that differs from semaglutide and tirzepatide. The main problem with GLP-1s that people don't realize is they cause nausea, vomiting, diarrhea, or constipation in a great many patients. And it's dose related. So the higher the dose, the more the symptoms are there and can be quite dramatic. They also cause significant inability to eat. People have no appetite at all. And again, if we don't replace the things that we're losing and keep our cells healthy, we are changing one problem for the other. So why did I choose liraglutide? As I investigated the semaglutide and tirzepatide, they are given on a weekly basis. So you give an injection every week. Now, if I understand that the side effects are nausea, vomiting, decreased appetite, diarrhea, constipation, I give an injection on Monday. That drug is in the person's body for a week, and they have all of these symptoms. And they're not going away until it wears out of your system. Liraglutide is given daily. So that means if it's given on Monday, it's out of your system by Tuesday. Now, why is that important? Well, there's two parts to the equation of taking care of patients. If you're going to give a supplement or a drug, you want them to feel good, and you want to minimize side effects. And so if the side effect panel is very, very high, then the drug or supplement doesn't make any sense. So tirzepatide and semaglutide, I don't like the fact that they're in the body for a week. That's number one. Number two, the weight loss with those two products, semaglutide and tirzepatide, is dramatic. Slower weight loss is much healthier for the patient. Malnourishment is at the cellular level. If we lose weight slower, we're less likely to be malnourished. So when we talk about liraglutide, we basically have 5 levels of dosing. And basically over a 35-day period of time, and that's our therapy, it's a 35-day cycle of subcutaneous nightly injections. And you increase up to a point where their symptoms may be a problem. And then at that point, you stop. Symptoms meaning nausea, vomiting, diarrhea, constipation, no appetite. We don't want those symptoms. So we, at Epiphany, typically try to just use an increasing dose to maybe the 3rd level, and then try to keep them on that level as an anti-inflammatory and a weight loss combo. So 2 35-day treatment cycles. The expectation for weight loss would be anywhere from 15 to 30 pounds. So nothing dramatic like the semaglutides or the tirzepatides. Now the problem is if you are talking to your friend and they've taken semaglutide and they've lost 50, 60, 70 pounds in 3 months, the context for you is that's what liraglutide should do. But we don't want to do that.
Yeah, I think that's something that people are starting to notice after they've been on tirzepatide or semaglutide for a while, is that rapid weight loss, but they did have to keep increasing their dose to actually continue losing weight. And then on top of that, it was more just like this door with a stuffed closet, and as soon as they let go, all the weight comes back. So I know for you at Epiphany, you mentioned the lifestyle and the nutrition and activity. So when you're managing your patients and it's this slower weight loss, are you having that patient also be a part of the journey and working hard to change their activity, change what they're eating, change their lifestyle, so that when you stop the cycle, they continue losing weight or continue maintaining their weight loss?
So I think you have asked a fantastic question that is the difference between traditional medicine and longevity or functional medicine. Traditional medicine, again, is a disease-oriented state where you have a disease and then the doctor tells you what to do. If you look at longevity or functional medicine, it is patient-centric for them to be part of this journey. I'll give you an example. So you come in to see me and you are 220 pounds. And your goal is to be in the 100 range. And we think that's a very good journey. So I'm going to take you at 220, and our goal is to get you somewhere around 190. So you have a 30-pound weight loss. So we would say to you, okay, Understanding that you're here, we want to be here, so we have an end goal. And how do we do that? So we would offer liraglutide, and we would say, okay, you're going to be on this dosing, you're going to do subcutaneous injections, and we would do 2 rounds of 35 days. Okay, so that gives you adequate time from a drug standpoint. Now, lifestyle. We would want you to, again, get a good night's sleep. We would want you to try to reduce stress because, again, stress increases cortisol, which increases insulin, which causes you to gain weight. So reversing that is very important. So reducing stress in your life with a lifestyle. Diet. We would want you to go on an organic format. We strongly believe in high protein. People get tied up on this calories, this caloric intake, and they spend a lot of time worried about the calories. We believe at Epiphany that if you just simply count protein, and as a woman, you want around 100 grams of protein per day. A man, you want somewhere between 120 and 150 grams of protein per day. In addition to the high protein diet, we want you on a high fiber diet. Now, that doesn't mean Metamucil. That means blueberries and chia seeds and kiwi and apples. If you do just those 4 things a day, you get to 35 grams of fiber. Think about the way a teeter-totter works. As the fiber goes up, insulin comes down. As your insulin comes down, you lose weight. As your protein goes up, your insulin comes down and your weight goes down. And then the third part is just watching where you're at from an activity standpoint. I've got an iWatch on here. It has a step counter. My daily goal is a minimum of 5,000 steps. So liraglutide, nightly injections, lifestyle. Go to bed every night at the same time, try to minimize your stress, get UV radiation from the sun or from a red light therapy. Diet, you eat organic whole foods, you try to have a high protein diet, try to have a high fiber diet, and then activity, you try to have 5,000 steps per day. I want to mention maintenance of GLP-1. The GLP-1, semaglutide, and tirzepatide are maintained for patients, but with no goal, no end game at all, okay? Just that you're going to take this dose until the cows come home. They go to their family doctor, their internist, they say, I want to lose weight. He writes the script. Literally, he can be in the room 30 seconds and walk out. A lot of times they don't even follow weights or blood pressures or anything like that. Now, as far as maintenance therapy, if we're talking about using the GLP-1s for reducing inflammation, that can be every day of their life. And so back to my liraglutide. If we give the lowest dose or the second lowest dose and give that subcutaneously every day of your life, it is a great anti-inflammatory.
So back to the nutrition side of things, liraglutide is helping them lose weight slower, and they're having fewer side effects, and the risk of them not having an appetite is not as severe as with tirzepatide and semaglutide. Is there specific vitamins or supplements that you tell your patients you need to be on these, especially while you're on GLP-1s?
The answer to your question is yes. When you're on the GLP-1s, you run the risk for having the inability to absorb minerals and vitamins. And minerals and vitamins, I'm talking about excluding the caloric part of food, the energy part of food. I'm talking about the vitamins and the minerals that we need to obtain through our food. Many times they're not in our food. And if our calories are markedly reduced, we're going to have markedly diminished vitamins and minerals enter our body. So you have to understand that this is a real problem. And again, it's education for you as the patient.